Loving Heavenly Father, we come before your presence. We invite you, Lord, to come to us, to teach us, oh God, to learn things today. And may this help us in our practice, help patients who are suffering from these problems, and be able to share this information to them and guide us in all our efforts. Thank you, oh God, for your grace and for giving us another life, another day. In Jesus' name we pray. Amen. So, good morning, everyone. You have me again instead of Dr. Galucio. So I hope it will be all right with you. I will be sharing with you a talk. Okay. Okay, hold on. Hold on a second. Okay, can you view my slide already?
Yes, Dr. Jim, clear.
Okay. Okay, so good morning, everyone. So my talk today is about sports hernia, and let me see if I can, because there are people who are still coming in, and there are people who are okay. So sports hernia is a very interesting subject, and I know a lot of you here have also some experience on this, and I just would like to share whatever experience I have to all of you. And this is very common, especially for sports injury. Those of you who are seeing patients who are playing soccer, or maybe in some place where you are playing ice hockey, or any even basketball for some unique reasons, you might even have this. But this is not really a hernia. This is a sports hernia, but as I mentioned, this is not a hernia that's causing this problem. So what is a sports hernia? This is a growing pain. This is a pain that arises from the inguinal area, caused by sudden acceleration and side cutting. If a patient is an athlete is maybe working or playing, and then suddenly he uh, encountered some challenging work task while undergoing an activity, then he will have to experience some uh, kind of a pain on the growing area. And the challenging part of this problem is that it could be diagnosed in many different ways. So it could be, to some people, an osteitis pubis. It could be, to some people, an adductor tendinitis, or it could be a tendon avulsion, or it could just be a myofascial herniation, or some people might even see this as an inguinal nerve entrapment. I'm sure if you have heard about Dr. Chi Peng Lin lecture, you have to figure out that there's a particular nerve there that innervates that area at the periinguinal area, which could be entrapped. And this could also be one reason for this entrapment and pain on that area. Or as we would expect it, because our lecture is about athletic pubalgia or sports hernia, it could be a tear or tendinosis of the rectus abdominis and adductor longus muscle. This is like a chain muscle that could be injured in that particular area. So for whatever reason, all of this could be possible diagnosis for problems arising from that area. So this could be correct depending on what mode of diagnostic procedure we're doing. but it is very important that we consider all this as possible diagnosis. So our objectives of this talk is actually to review the anatomy and the structures that are involved in all these areas, and of course to discuss also the scanning technique, and of course to describe the findings that could be seen in athletes suffering from pain on that particular area, their differential diagnosis as we have mentioned earlier, and what possible interventional procedures can we do when we actually treat patients with this particular problem. Now, the other thing is what is the role of ultrasound in this patient? So it is very interesting that the ultrasound is not really the mode, the choice of diagnostic mode for this particular case. Still, it's the MRI, but the ultrasound has a very important role in trying to get a quick way of diagnosing it and seeing what exactly are the problems that we will be seeing. So it is important that we see what are the anatomy involved and how a normal anatomy would look like in this particular area. And then, of course, a very thorough understanding of the sonographic image in this region is also important, and how they come into play in trying to diagnose a particular site if there is any pain. So putting all those differential diagnoses in mind, we have to always check that the nerves, the pubic area, and the other structures that might be present is very important in order to find out what really is causing the pain in that particular part of the pubis, and of course the inguinal area. And of course, why ultrasound is important is because it gives us a real-time diagnosis of an injury. So if you are working in a place where you need to make a diagnosis, especially for some of you here who is involved in sports medicine, then it would be helpful for you to really do a real-time diagnosis of that particular area. And then, since it is possible to injure one side and spare the other one, then you can also compare side to side, right and left, how they look like and how do they appear in the ultrasound. But also at the same time, it is possible that both sides could be injured at the same time. So just keep that in mind, because it could make or break your diagnosis as to how you can approach this. And one thing also that is very interesting here to know is you need to have a very high spatial resolution of an ultrasound. Maybe if you're using a simple type of ultrasound, you might not see any change at all, because the changes that you see, the subtleties in the diagnosis might not be very obvious. And then, of course, also you have to do some dynamic maneuvers in order to highlight the specific structures that you would like to see. And one of that maneuvers is to do a Faber's positioning. You do a femoral abduction and external rotation in order to see all the structures stretch in that position. And at the same time, since this is not really a hernia, but one of the differential diagnoses could be a hernia, it would be also nice to do some Valsalva maneuver just to rule out the possibility of having a hernia on that area, which is, as we are talking right now, is not really a true hernia, but it is just a term referring to a sports hernia on that area. So how do we do it? So usually we follow a systematic way of scanning that area. So first we have to scan where the pain is as noted by the patient himself. Then do a Faber's positioning in order to see the structures that we're looking at, and then also apply some graded compression on that area where we are doing the scanning. Then make sure you do an orthogonal assessment, do a short axis first, and then do a transverse assessment of the area to include not only the inguinal ligament, the muscle itself, where we are trying to view the rectus abdominis and the adductor longus, but also the pubic symphysis, if there's any diastasis or any rupture in that area. Then, of course, we also have to check the femoral neuromuscular bundle by exerting some Valsalva maneuvers in order to see whether we're dealing with maybe a hernia, which is not related to the sports hernia. Then some of these patients, by the way, may have complaints that might just be referred to that area, but actually they could be initially be part of the anterior hip. So part of the anterior hip is the possibility of a labral tear. Of course, the specificity of ultrasound is high, or although the sensitivity is low, but then we can still see some signs there that could point out to any signs of labral tear. The other thing that is very interesting is the femoroacetabular impingement. So it is also important that when we see sports hernia, we also assess for any deformity that might happen in the acetabulum, but at the same time happening in the femoral head, which is part of the femoroacetabular impingement assessment. Okay, so here, normally this is what we see. So what are the muscles that are attached to the pubic symphysis? So if you look at this illustration here, so primarily we have the rectus abdominis, which is the most medial and most anterior muscle that we see here. And then of course, the rectus abdominis will kind of merge with the rectus abdominis. And then of course, we have also the internal and external oblique, which is also present and still related to the pubic symphysis as well. So keep this in mind. But of course, the most important of all these three muscles from the abdominal muscles are your rectus abdominis, of course. Then we have your adductor muscles. Now, the adductor muscles are made up of the following. We have, of course, the adductor longus, which is actually connected directly to where the attachment of the rectus abdominis is. So where the rectus abdominis ends, that's where the adductor longus starts. But going laterally, we have the adductor brevis, we have your pectineus, and we have your adductor magnus. All of these are actually inserted into your pubic symphysis, but in a different sequence. The only one that is directly connected where the rectus abdominis ends is your adductor longus. That is why it is very obvious that we see this connection between your rectus abdominis and adductor longus in your athletic pubalgia, or what we so-called a sports hernia. And then, of course, as we see these structures, you can see here the attachment. There is just really a fascia, or should I say an aponeurosis, that connects those two muscles. So if you look at it, it's kind of contiguous from the rectus abdominis down to your adductor longus. So these muscles are really, really connected. So if one muscle will be injured, it is always safe to assume that maybe the adductor longus will also be injured, but it doesn't always happen all the time. Sometimes one segment of the muscles may be injured, but sparing the other one. So in other words, it's possible that you only injure the rectus abdominis, but you don't injure the adductor longus, or you can injure the adductor longus and spare the rectus abdominis. So depending on how the injury happens, it could also happen that way. Or it could just be injuring the aponeurosis itself and creating a cleft on that area, and that is the reason why the pain is directly on the spot where the pubic symphysis is. And it's very interesting to just note that, just to be sure that you see the specific area that is affected. Of course, here is the normal appearance of the MRI, the ultrasound, and of course, how it looks in the cadaver. So if you look at the ultrasound, for example, the rectus abdominis and adductor longus is made up of a very thin layer just anterior to the pubis. So you can almost see just the fascia that's connecting it right anterior to it, and it's contiguous. You can actually follow that from your rectus abdominis down, going to your adductor longus area. And in the MRI, uh, although it's well defined, unless it is structurally damaged, then there will be some changes there. But as you can see here, there's really no significant findings that you can see there. Now in the cadaver, you can almost see the continuity of that muscle. And what interrupts that only is the bone right in the middle, which is the one that where those two structures are really attached. So that is how it looks like both in the MRI, in the ultrasound, and of course in the cadaver. Now the other thing here is that when you scan, as you assume the flexion, abduction, external rotation position, or the Faber's positioning, you will notice that from a straight line, okay, from the rectus abdominis going to your pubic symphysis, it's usually vertical. But as you go to your adductor muscles, then you go oblique. So it's like a diagonal move going externally to follow those three adductors. But as you can see here, there are actually 3 layers of muscle that you will see eventually, which are your adductor longus, then you have your adductor brevis and adductor magnus in sequence from the most superficial to the deeper layers. So as you can see on top, it would just be purely your adductor longus. So it is continuous on the pubic body, and that is also the positioning of your ultrasound probe right here. So your transducer coming from the rectus abdominis will be moved over the pubis and then go sequentially a little oblique externally to be able to follow the adductor longus stretch of the muscle. So here, this is another way of viewing it. So patient now is in a Faber's position, or what we call the frog leg position. And then you can see these 3 layers of muscles. So you have your adductor longus, then adductor brevis, and adductor magnus. For those of you who are doing some nerve scanning, you will notice that there is a very small muscle, a nerve in between those layers of muscles. So for example, between your adductor longus and brevis, we have your anterior obturator nerve. And then between your brevis and magnus, you have your posterior obturator nerve. So you can see this to be attached commonly at the pubic body. And so you can see all those 3 are separating by a fascia where those nerves are located. So this is the correct positioning of the ultrasound when you try to scan them. So you go vertical first at the rectus abdominis, then as you raise the pubis, you go oblique, and then follow the layers or the fibers of the adductor longus. And so you are in the oblique position now to scan the adductor longus muscle. So here, I should go lateral. You can also see additional structures. And the reason we have to not inform you this is because the femoral vessels are also on that side. So you have the nerve, the artery, and the vein. So you have to realize that all these structures are just very close to each other. And so as you see the inguinal ligament on top in the transverse view, you can also see not only the muscles medially, but also the femoral vessels laterally. So when you see this, it only points you to the possibility that this structure could some kind of interfere with your images. And so you just have to be aware of those structures that might interfere with your scanning. So it's always best to turn on your Doppler to be able to see the vessels that is located on the lateral side. So here is another picture of how it looks like when you do the transverse view. So you can see here the symphysis pubis at the middle. Then you can see the pubis on both sides, right and left. And then just on top of that is the ligament. We have the ligament right on top of the symphysis pubis. And this is a normal view of the structures. So you can see a beautiful, uh, very regular symphysis pubis, and of course the pubis bone itself. And then you have the muscles right on top of it. Now, what happens when you have your athletic pubalgia? Now, there are so many findings that you might possibly see depending on the abnormality that you will see while you scan it. But what is important here is when you try to look at the rectus abdominis, abdominal adductor longus tendon, it is important always to compare the right and the left, as I mentioned earlier. And usually tendinosis will always show us thickening of the tendon, depending on which tendon is affected. It could be just purely your rectus abdominis, insertion on the pubis, or just the adductor longus. So when you start scanning on top, then when you see and you compare the right and the left, and you have the hypoechoic thickening, then you can see it's more pointing to the tendinosis. Or it could be itself an injury that could be the bridge between the adductor longus and abdominis. In other words, you're not quite sure whether it's really on top, which is rectus abdominis, or below, which is adductor longus. So it's in the middle. And if you look at the insertion, as shown here in this ultrasound findings, there are cortical irregularity. So if the cortical irregularity is seen right on the insertion itself at the pubis, at the mid portion, then you can see that the injury is at the aponeurosis itself. It's neither the rectus abdominis or the adductor longus, but it's in the middle area. So here, if you will notice, there is hypoechoic swelling on the mid side, which is really where the attachment of both the adductor longus happens and the rectus abdominis. So this is more of an aponeurosis injury. It is also possible that there could be a detachment of the structures on the rectus abdominis side, or the detachment of the structures on the adductor longus side. Or sometimes if the tear is really big, and this happens when there is a rupture of the rectus abdominis, it could retract proximally and can create a bulge at the wall of the inguinal canal. And when you apply a Valsalva maneuver, it kind of pushes the anterior abdominal wall forward, and this could be a sign also that there is a rupture actually of the rectus abdominis. Other things that are also seen is, let's say you are dealing with an osteitis pubis. So the findings that could be found there could be just a cortical irregularity, spurring, effusion, and then there is a separation between the two sides of the symphysis pubis. So if you measure the distance, usually it's more than 2 millimeters. So that would indicate that there is a separation that happens at the symphysis pubis. And then you apply also some pressure on the site, and there is tenderness, then that could also contribute to the sign that you are dealing with some problems right there at the insertion of those two muscles at the pubis. So here, this is an adductor tendinosis. This is a 31-year-old triathlete. And what we see here is that there is a swelling, hypoechoic swelling right at the insertion of the adductor longus. So we can see that there is also cortical irregularity right where the insertion sites are. So this is really an adductor longus tendinosis. So if you compare it with the normal side and the right, you can see that there's really nothing there. But if you move it to the left, where the ones involved here during the kicking area, kicking movement, then you can see here that there is a very swollen attachment of the adductor longus tendon. So this is more of an adductor longus tendinosis. You can also see a cleft sign, which is described to be a cortical irregularity with a detachment of your rectus abdominis and of course the adductor aponeurosis. So you can see here as like a cleft. That's why it's called the cleft sign, because both if you look at this arrow here, okay, both these pubic bone from the side of the abdominis and from the side of the adductor longus are stretched. The cleft is stretched all over. So the irregularity is also distributed all over the area. So this one is an indication that both the rectus and the adductor aponeurosis with the longus, of course, the attachment is involved. So this cleft sign is indicative that these two muscles are involved, the RAL, the rectus abdominis, and the adductor longus. So they call this an early sign, or should I say, an acute sign of an injury that points to an immediate treatment for patients suffering from a sports hernia. This is an MRI findings, and you can see the difference between the bone marrow edema and the detachment itself. Of course, for those of you who are familiar with MRI reading, you can see here that there is really an intensity on the area where the tendon is attached, which is signifying that there is some problems that's happening in that area where the patient is complaining. And this is really a bilateral injury. Now, for chronic cases, for example, these patients may not be complaining of significant pain in the beginning, but sometimes patients would come and go, will undergo physical therapy and complain again of pain, and then you allow them to play again, and then they will again complain of pain after a particular game, and then they will go back to sports again. Eventually, if you check their area, you will be able to see a calcification on those areas. This happens because of the chronicity of the injury. They come and go. They play again. They have injury. They play again. They injury. Play again. So because of that, they will develop calcification in this area, which is painful. And this only signifies that there has been an injury already going on, but then they allow themselves to play again, and then they develop all this calcification. So the approach to treatment would be different when, and we will discuss this later on, for patients with calcification, and then of course here also showing a partial tear of the adductor longus tendons. Now, same findings here. There is a calcification in the attachment of the tendon, and then of course there is a cortical irregularity on that site, and then there is a mild swelling. You can see here in the hypoechoic area right on top of the cortical irregularity of the bone, the pubis, signifying a tendinosis on that area, not really rupture yet. And then of course, this one is a combination of a tear, the one on the left, with a bony avulsion. So the bone is ruptured, okay, and the aponeurosis is also detached. So the continuity is really interrupted, and you can see here the hypoechoic swelling on the area of attachment. And so this one is a little serious, and for this reason, conservative therapy might not be appropriate for this particular patient. But of course, on the other side, you can see here a tendinosis. It's just a swelling, but there is no tear that could be seen on that particular image. Now, this is a transverse view where you see that the plate itself is involved. So as you see, and scan the transverse view, actually you can see the right and the left. And you can judge based on what you're seeing there if something is really wrong. So as you can see here, there is already cortical irregularity that is happening. And of course, there is also hypoechoic swelling on the attachment of those bone from the rectus abdominis and adductor longus. So here you would see an obvious sign that the aponeurosis plate is also involved. So here, as I mentioned earlier, it is possible that with a rupture of the rectus abdominis, it is possible also that there will be bulging that could be seen on the anterior abdominal wall. And as you can see here, the inguinal ligament is just right on top of the neurovascular vessels. You can see here the rounded structures. These are the neurovascular structures. And if you follow that inguinal ligament down to the right, then you can see here that there is some kind of a swollen area. And this is really a ruptured rectus abdominis over here. If you apply a Valsalva maneuver, what would happen is that would bulge when you exert some force on this area. And usually you will notice this to be on top of the inguinal ligament. And this is also one sign that that rectus abdominis is actually ruptured. So if you will see the drawing here, I should follow it. The reason why I included this is because just for you to see how the other structures would relate to the rectus abdominis. And so just for you to find out that you can also see there the round ligament and of course the superficial inguinal ring. So it's almost close by, except for the fact that you can see that actually when you exert some Valsalva maneuver, it is usually bulging. Under normal circumstances, that should not happen. But in this case, when you exert a Valsalva maneuver, then it pushes the anterior wall right in front. So here is another example of inguinal hernia. Of course, it's a part of the lecture, but at least you've seen how it looks like. And of course, as I mentioned earlier, symptoms of athletic pubalgia or sports hernia could actually be referred from a problem that can come from the labrum. And any labral tear, for that matter, any labral injury could also be referred to the anterior wall of the abdomen. And that could also simulate some parts of a sports hernia. But of course, if you see it to be normal, and if you scan the anterior hip, you see some defect there. It should have been a triangular hyperechoic structure, but you don't see that. So it's an indicative of a labral abnormality, and you can counter-check it by doing your MRI. So the lesson here is that when you see no abnormality, for example, in the rectus abdominis adductor longus segment, you have to see and check also the anterior hip and find out if there's any abnormality here. So the symptoms in this patient could be partly because of the findings here in the labrum. Another thing is if you are entertaining a femoroacetabular impingement or FAI, the best thing to do is to flex the hip back and forth to see if there is any abnormality or any impingement as you move it. Usually it could arise from the acetabulum or it could arise from a defect in the femoral head. So either of them could cause femoral acetabular impingement. So treatment options. Well, most of the time, what is available for us, of course, is either a physical therapy. You can do adductor tenotomy. You can do injection. Just avoid steroid injection at this point, although it could give you an immediate pain relief. It may make the tendon more brittle and susceptible for another rupture. So you can do your regenerative treatment, PRP, or whatever you have. And then, of course, depending on the extent of the injury. If there is really a full-blown injury with bulging, then the only way that we can do treatment for that is, of course, surgery. But these are all options that we can do for our patients suffering from rectus abdominis, adductor longus, or athletic pubalgia problem. So return to play. Usually, the return to play is very high if the patient have been properly treated and diagnosed. 95% of them can go back to their previous level of injury within 3 months. So there's a lot of protocols. If you try to see the protocols for sports hernia, there's just a lot of them. But depending on how you would like to do it, usually if it's successful, so within 3 months post-surgery, you can already return the patient back to their usual level. If you're just doing physical therapy without surgery, you have to be very cautious because, as I mentioned, if there's a chronic recurrent tear, there could be a calcification that you might really need to ask for consult with your orthopedic friends and ask them if they would decide for surgery, because a lot of them could be treated that way and could resume back to their normal activities. Now, 39% of patients would have femoral acetabular impingement, in which case, once they're treated, they can always go back to their usual activity. And of course, a small proportion of them could still have some problems when they return back, and so expect it to always be monitored closely, because some of the patients that you might want to let them return could still have those deficits in spite of all the treatments that you've given them. So again, thank you very much, and I think this is all for today. And I would like to thank everyone for patiently joining us in this lecture series in the Zoom. And I don't know if you have any question. If you have any question, then please share your question to us. If you want to share any of your thoughts, you might want to share it as well. If you have any experience. Any question? Hello?
Thank you, Dr. Jim, for the lecture.
So I just would like to make an announcement. As I mentioned, on tomorrow, we're supposed to have a lecture by Dr. Monaco, but he just informed me today that he might not be able to do it because of some challenges in his workplace because of the schedule. But as soon as he gets back with his normal activity, then I think he will send me the schedule. So, but what is certain about our activity for this week is that we will have our lecture with Dr. Kirshner on the ankle and foot by Thursday, 9 o'clock. Okay, there's a question here. Okay, go ahead, Pash. Do you have anything in mind?
No, Dr. Azmi has a question, Dr. Jim.
Which is better to inject locally? Of course, I think I have a bias for that question because I don't really do steroids. I would always initially inject PRP rather than steroids. We know that, and we understand that the steroids will make the tendon more brittle over time. So if our purpose is just to relieve the pain, there are other things to do that physical therapy can address that. But if we are looking at strengthening the tendon or regenerating that area, especially for partial tear, okay, then PRP would be the best option for this patient, especially the high density PRP. Okay, go ahead, Pash.
Doctor, when you assess for, let's say, a possible tear or, the pathology in the rectus abdominis area, do you do it also doing some dynamic testing to confirm?
Yes, yes, very nice question. Yes, because the reason why you have to do the dynamic testing or the stress testing, as we call it, or maybe is to highlight the structures. Because sometimes if you don't do that maneuver, you may not be able to see the entire length of the tendon, especially the adductor longus muscle. Usually they are lax in that position. So you might see them, but you may not be able to see them quite well as compared if you actually apply that flexion, abduction, external rotation motion. So for you to see that, that would be really the best. Yeah.
Thank you, Dr. Jim.
So any other comments, questions?
For any injury, Dr. Jim, after the orthobiologics, let's say it's just a partial tear. How many do you allow the athlete? Let's say it's an athlete to return to play immediately, or do you wait for like 3 months before you allow the patient to do any activity after?
Yeah, if it is a conservative treatment and addressed to patients who have only partial tear, let's say, let's just put it this way, it's a rectus abdominis problem. If it's a rectus abdominis problem, usually a physical therapy should be done. And I think Miko is here. Miko, are you here? Because part of these problems has to do with the core muscle, actually core strengthening muscle. A lot of that injury is due to the fact that there is weakness of the core muscle. And since a lot of these injuries also happens at a time when they are not really ready, or should I say, this is an accident. So the sudden cut and the sudden acceleration are the forces that contributes to that. So when you look at it that way, much of the rehabilitation would be focused on core strengthening actually. So all of the exercises would be that until such time that the patient survive in terms of pain, then this will take maybe about the usual protocol that I've seen here is about 2 months. When you finish 2 months of extensive physical therapy, then that is if you are doing it conservatively. But if there is an aponeurosis tear, there are people who are saying that it has to be surgically operated. Of course, there are advocates for rehabilitation only, but eventually, after a certain time, if there is a re-injury, then they have to do surgery again. So an aponeurosis tear, meaning there is the attachment of, there's the cleft sign where there is attachment of the rectus abdominis and adductor longus are both involved, then they are advocating the treatment by surgery, so that they can ensure that it is really attached back and back. But this is safe because in most cases, as we mentioned earlier, 95% of patients will always return to play in 3 months. Yes. Okay, Pash.
Let's say, Doc, you had a patient who underwent surgical, procedure to correct the tear. Do you also suggest using orthobiologics after that, just to improve, the treatment or to make it better? Or is there no role for orthobiologics after surgery?
Yeah, there's always a role, especially during the healing phase. The healing phase is very important because the orthobiologics will actually enhance the healing phase more as compared when you don't do anything. So, but there are no actual study comparing that the effect of orthobiologics with surgery and orthobiologics. So there are no specific studies. So what I'm just saying is, theoretically, it could hasten or enhance healing, although no studies have actually proven that yet. Now, there's another question here. What exercise to strengthen core muscle you suggested? There's really a lot of them. So actually, if we have to include it here, it will require another lecture just for the exercises. I think you just watch out for that, because Miko, Dr. Mike Obispo will give a lecture specifically on ultrasound guided core muscle exercises. So just watch out for that. I think that would be on the last week of July. He promised me to do it on the last week of July or first week of August. And that is primarily just for that. So there's just a lot of them. So, and they are just called core muscle exercises. So many of them. It could include your muscles on the proximal thigh, the distal abdominal muscles. So all of those muscles will be included in the core muscle exercises. Okay, so thank you very much again. And thank you for really keeping up with all these challenges that we are facing. And as I mentioned, there will be no lecture tomorrow by Dr. Sorry to disappoint you, because Dr. Monaco is still finding a time. We initially scheduled it tomorrow evening, but because of some challenges in his workplace, I think he asked me to postpone it a little bit. We'll just wait for the announcement. But what is certain is Dr. Kersner on Thursday, 9 o'clock, he will talk about ankle and foot. I know this will be a very, very nice lecture by Dr. Kersner. So, and then next week, we will have Dr. Mederick Hall from Mayo, and Dr. Jojo Domingo will also give a lecture. Can you believe that? So thank you very much, and have a good day. God bless everyone.